don't think so. Point your hand. Hi everybody, how you doing? Thank you very much for coming along to this month's Morris Block lecture. We are very kindly joined by Dr. Rebecca Richmond, all the way from Bristol, who's very kindly come up on the train this morning. So Rebecca has, like I said, joined us from Bristol. So what we're going to do is have a talk from Rebecca about some of her research interests and some of the things she's found over the years. Then we'll have a brief Q&A, and you have the opportunity to ask Rebecca some things about her research. So a little bit of background. So I was, until recently, I put my foot in it this morning, a Vice-Chancellor's Fellow at the University of Bristol. So not anymore. She is, however, a senior research fellow in molecular epidemiology at the MRC Integrative Epidemiology Unit at the University of Bristol. She's ostensibly a researcher in physical and psychological health, but looking down her list of publications, you quickly realise that there are loads of specific subtopics within that, all of which are very interesting. So things like sleep health, maternal health, psychological health, and also things like research biases, so things like contrasting self-report versus electronic health record data. These things have impact because the findings have implications, whatever research topic someone's investigating. Her work, this isn't written anywhere, by the way, this is genuinely just my impression of her work. Her work integrates genuinely complementary approaches to triangulate causality, so things like Mendelian randomization, which is a genetic epidemiology method, epigenomics, DNA methylation, but also large-scale routine data sets like CPRD. Rebecca's done a lot of work on robust methods, so things like strobe statements from Mendelian randomization, molecular mediation at the epidemiological level, and she has a genuinely enviable publication record, not only in terms of citations and impact, but in studying fundamentally interesting topics, I think anyway, in genuinely cutting-edge ways that I, for one, certainly aspire to. So to give her more formal biography, Rebecca is a senior research fellow at the University of Bristol. She's currently undertaking a secondment as a genetic epidemiologist in the Oxford Health Biomedical Research Centre theme in Better Sleep. Her research aims to, firstly, highlight the relative importance and interrelationship of sleep and circadian rhythms with other health behaviours for prioritisation in disease prevention strategies, and secondly, to identify molecular pathways which could serve as targets for intervention. Her major areas of focus are on the large-scale integration of molecular data in population-based and clinical health science, as well as the development and application of causal inference methods, including Mendelian randomization. Her talk is entitled Examining the Causal Role of Circadian Rhythms and Sleep in Physical and Psychological Health. So without further ado, if you'll join me in welcoming Rebecca to stay with me.
Hey everybody, it's great to be here. Yeah, just wanted to say thank you so much to Donald for the kind invitation and also that very kind, I'm not sure, fully deserved introduction as well. So as Donald says, I'm a senior research fellow at the University of Bristol, where the type of research we do, obviously people probably have heard of Mendelian randomization, which I think is what Bristol is, or the integrative epidemiology unit is most famed for. But increasingly we're interested in using other sort of causal inference methods for appraising fundamentally important questions regarding health behaviour and disease risk. A health behaviour that I'm particularly and have increasingly become more interested in is sleep and circadian rhythm disruption. And this has sort of prompted my sort of move secondment to the University of Oxford, where there is a huge amount of expertise in this field. So I'm currently working within the Biomedical Research Centre there on their better sleep theme. So sort of leveraging some of the skills that I have in genomic and molecular epidemiology applied to this really interesting area. So I'm going to give some examples of the sorts of research that we're doing, the data sets that we're leveraging, and the approaches to tackle some important questions regarding the importance of sleep for physical and psychological health. Okay, so yeah, just by way of background, in terms of circadian rhythms, what we mean by this is those endogenous near 24-hour rhythms which regulate physiological processes. So the most obvious being the sleep-wake cycle, but also circadian rhythms are fundamental to hormone regulation, temperature control, and they're driven by an internal clock. So the super chiasmatic nucleus, which is located in the hypothalamus, is often seen as the sort of central master clock, which governs the sort of 24-hour rhythm. But there are also peripheral clocks working in a more tissue-specific manner as well. While this is a sort of intrinsic clock, so it could be sort of ticking along with the absence of external stimuli, it's sort of fine-tuned by some environmental stimuli. So most obviously being the light-dark cycle, but also other sort of termed Zeitgebers, which includes things like social cues, timing of exercise, as well as food intake. So simply, when healthy, the internal clock is seen to be entrained or synchronized to the external world. And when the circadian clock is misaligned, this often manifests as disruptions to the sleep-wake cycle, sleep disorders, and also potentially might contribute to disease risk. So now thinking more about sleep in itself. So poor sleep is a common phenomenon, sort of increasingly common in the modern world. So 13% of adults report poor sleep quality, around 20% report insomnia symptoms. There's really nice study conducted a few years ago now, aggregated data from different countries and across different age ranges, to really demonstrate this phenomenon of poor sleep, and particularly the decline in sleep quality and sleep duration as we age. We know that a number of chronic diseases are associated with poor sleep, including cardiometabolic disease, cognitive decline, some forms of cancer. But what we don't know is whether sleep represents an underlying sort of causal mechanism which could potentially link all of these morbidities. And that's the thing that I'm really interested in trying to unpick, is the extent to which sleep is causal for some of these disease risks, as opposed to a consequence or a biomarker of disease. So sleep epidemiology, I think, has been on the rise in recent years. So this is a study from Susan Redline a few years ago, showing the increase in the number of papers that mention both sleep and epidemiology. I think that the rise is in a large part attributed to the availability of large-scale data that's now databases that are now collecting measures on sleep. So thinking of studies like the UK Biobank, where sleep is being more recognised as an important behaviour that we need to measure and capture. So I mentioned the UK Biobank, also showing here a number of other studies which we're kind of increasingly leveraging, which have got detailed measures of sleep obtained from self-report questionnaire, actigraphy-based measures, so sort of objective measures, for example, from wrist-worn devices, as well as electronic health records, which primary care reports of sleep disorders. So I'm going to talk today about a range of these resources which we're using. Some, I'd say, people will probably be very familiar with, others more new resources. So thinking of the All of Us, which is a sort of US-based equivalent to the UK Biobank, as well as the China Kadoorie Biobank, which I've been working with a bit through my links with Oxford. There's also the Hunt study, which is a Norwegian study who we collaborate with, and who have also got detailed sleep measures and actigraphy data. 23andMe, which has probably been the largest genetic-based studies of self-reported sleep. People will probably be sort of aware of the challenges of 23andMe, and it's actually been bought out at the moment, but it's still, it's, as I say, a very large resource that we have collaborated with and have obtained data from, has allowed us to do some quite interesting research. I'll show an example of where we've looked at spouses who often have sort of obtained 23andMe data at the same time to look at the sleep patterns within those individuals. Oh, and then finally, the CPRD, which is a sort of record linkage study, which we've been leveraging as well. So to zoom in on the UK biobanks, so this is a study that I'm sure a lot of people are very familiar with, and is also a very rich resource for looking at sleep data. So when the participants in this study were recruited back in the sort of early 2000s, they completed quite a basic sleep module questionnaire comprising these 7 questions. There's been some repeated follow-up of a subsection of the cohort at multiple time points. Around a fifth of the cohort wore an accelerometer device continuously for 7 days. That was about 7 years after the baseline. And there's been various online follow-up questionnaires, so one about shift work history, and one specific one that's just recently been released and is very exciting on a detailed sleep questionnaire as well. We can also leverage the genetic data on the majority of participants in this study, which has been really groundbreaking for identifying sort of novel polymorphisms which underlie sleep traits. And also we can link with the socio-demographic, lifestyle and health and disease data as a way to make inferences regarding causality of sleep. And then just sort of demonstrated here are the sort of 3 main types of sleep data we can obtain. And I'll talk a bit more about each of these. So some work that a PhD student in our group has been doing quite recently has been looking at the comparison of people's baseline self-reported sleep or insomnia, specifically in the UK Biobank, with that which can be gleaned from electronic health records. So around half of the UK Biobank participants have got linked primary care records, and Mel, as part of this analysis, sifted through a load of read codes to try to derive insomnia from primary care, and then compared this with those self-reported cases of insomnia from the baseline questionnaire. The results were quite interesting, but I think very surprising. So in terms of cross-referencing, perhaps less surprising is that a number of the a large portion of the self-reported cases weren't picked up in primary care, which we would maybe anticipate sort of with underdiagnosis and under-recognition of sleep conditions. But interestingly, there were a number of primary care cases that also did not report to be a self-reported case at baseline. It may be, for example, that these people had sort of transient insomnia a number of years ago. They might have been treated for insomnia, that could potentially explain why they weren't reporting insomnia at baseline. But even individuals who had a read code of insomnia symptoms 4 weeks prior to the baseline and had been prescribed with a hypnotic were not reporting to be an insomnia case. So yeah, so there was just an over of 73% there. So it's quite interesting to look at the sort of disagreement disparities between these measures. And then on the right is an analysis looking at the self-reported sleep data with the actigraphy-derived measures. So this is sort of depicts the SR and then the SR being the self-reported, ACD being accelerometer derived. And this is actually an assessment of sort of the genetic correlation between some of these measures. So some of them, quite easy to compare in terms of sleep duration, where there's a moderate, maybe 0.7 correlation. Also quite strongly correlated in the middle are the self-reported chronotypes, that's morning, evening preference, and then the L5, so that's least active 5 hours, M10 most active 10 hours of the day, and these measures are strongly correlated. What are potentially less sort of correlated and what we were maybe surprised about is the self-reported insomnia with the actigraphy-derived measures of sleep efficiency and sleep fragmentation. So sleep efficiency being sort of time that we spend asleep when in bed, sleep fragmentation being sort of number of sleep episodes across the night. We might see these to be measures of sort of insomnia, but it is quite interesting that we don't see particularly strong genetic correlations there. And we'll talk a bit more about the sort of inferences of that. So as I sort of mentioned, these resources that we can use, and obviously we can look sort of observationally at these sorts of associations between the sleep measures that we're deriving in relation to disease risk. So sort of simply, we might look at individuals who have insomnia or no insomnia symptoms at baseline, and then investigate which of those go on to develop type 2 diabetes, for example. But we run into the sort of typical problems of observational epidemiology. So, for example, reverse causation, maybe an individual with undiagnosed type 2 diabetes is experiencing pain at night, is going up to go to the toilet, and so this is leading to the insomnia. Confounding, so for example, strong sort of potentially bidirectional links between insomnia and depression, and so it's important to account for some of these potential confounding factors in our analyses. And as sort of mentioned, alluded to, measurement error, so reporting bias, for example, and sort of previously, I think, limited power in these sorts of analyses, although I think we're overcoming that now with these larger data sets. So what the work in Bristol we really tried to do is to sort of bridge this evidence gap between the sort of observational study designs and the randomized controlled trials, which might not always be sort of achievable or very obviously time consuming to conduct. And we think about a number of different sort of causal inference methods or study designs which we can use to bridge this gap. So sort of thinking sort of simplistically about what we can do in observational epidemiology to adjust for relevant potential confounders, even considering, for example, Bradford-Hill criteria, to more sort of advanced methods, so thinking of sort of alternative scenarios to true causality, such as negative control designs, and then study designs that try to sort of mirror a randomized controlled trial. So, for example, non-instrumental variable analyses, target trial emulation, natural experiments, and also Mendelian randomization. So I wanted to talk about a sort of natural experiment that we've been doing in this space, which is the sort of observable phenomenon of the change in the clock, so the daylight saving clock changes. Again, this is work from Mel that she's done as part of her PhD. And this was really leveraging the accelerometer data from the UK Biobank. So a number of the participants within UK Biobank wore their ActiWatches over clock shift, either the spring clock change or the autumn clock change. And so what Mel wanted to do was to investigate how the sleep duration changed in accordance with the clocks. And she found that, yeah, maybe not to be unexpected, that there was a huge reduction in sleep, so a full hour lost with the spring clock change, which did show some recovery in the week afterwards. And then in the autumn, rather than it be the full hour gained, actually people were only gaining about half an hour additional sleep in that time, and then it quickly returned to normal. So showing, you know, the sort of population level, obviously there is this phenomenon of changing clocks is having an impact on how much sleep people are getting. So as part of her thesis, Mel's also interested in looking at the potential relevance of this. As say, it's a population level phenomenon. So if we see even small effects on, say, incident disease risk or acute events, then this could be potentially very relevant from a population health angle. So for this, Mel's used the CPRD, sort of record linkage data, to look at the dates of recordings of these events in primary care, and also in relation to the timing of the clock changes. So what's shown here are the adjusted rate ratios for the number of health events in the week after the spring and autumn clock changes compared with the control periods before and after the clock changes. So this is the spring clock shift, and here the results are maybe quite reassuring. So a lot of the literature would indicate an increase in events, particularly sort of mental health episodes, acute CVD, so myocardial infarctions, for example, as well as road traffic injuries. In this analysis, so probably the largest analysis that's been conducted in this field, the only slight increased risk we observed was with acute CVD with the spring clock change. But quite interestingly, in the autumn clock change, so that's the sort of gaining of an hour we actually find a reduction in the number of events for a range of these events, so road traffic injuries, sleep disorders, which is potentially expected, depression and acute CBD and anxiety. So results very interesting, I think, and yeah, I don't know how, sort of to what extent they would support. I think at the moment there is a sort of understanding that it will be better for the sort of standard times to be maintained, so not moving to the daylight saving time. The policy is probably not at the top of a priority list at the moment, but it's something that in Europe that they're considering doing, and so the UK may move in accordance with them. So this is obviously quite interesting work, but I think limited by the fact that we can only really look at this sort of natural experiment phenomenon in relation to acute events. So we can't really assess the extent to which this could disrupt sleep and have long-term implications for disease risk. So to be able to sort of move towards that, an approach that we've been using in relation to a range of contexts is Mendelian randomization. So to sort of briefly introduce this mimics a randomized controlled design by using genetic variants, so that's germline genetic variants that we inherit as a way to randomize individuals. So this is very much based on Gregor Mendel's laws of independent assortment and segregation, which says that the variants that an individual inherits should be largely randomized with respect to environmental factors, with respect to other genetic variants, and therefore could be seen to be analogous to the RCT design and the randomization there. So if we can look, for example, at an inheritance of a genetic variant that could influence insomnia versus a protective variant, if we assume that the confounders are equal between these groups, and then we can compare the outcomes between the genotypes as a way to infer causality. So as I say, this is a strategy that we use, but comes with a number of assumptions. So the sort of primary one being that the genetic variants that we're using are strongly related to the exposure. So in this context, that we might have genetic variants that are being robustly related to the sleep traits of interest. The big assumption of no confounding, so that is that these environmental factors won't govern which genetic variants we inherit. And then thirdly, the exclusion restriction assumption, which states that the genetic variant shouldn't be related to the outcome except through the route via the exposure. So this is also known as the sort of no pleiotropy assumption, which is something we can attempt to appraise within our Mendelian randomization analyses. So when thinking about doing this for the sleep traits, so as I said, obviously we can look at genetic variants related to various sleep phenotypes, but also thinking of sleep as the outcome, it might be interesting to look at how various sort of environmental or lifestyle risk factors actually impact on sleep. And I'm going to give an example of a few different studies that look at both the sleep as the exposure and the outcome. So in terms of genetic variants for sleep, so there's a really good literature, very well established understanding of the sort of core circadian machinery and the genes involved there. So the sort of central genes. So period and cry, working this sort of complex and a negative feedback with BMAL and clock. And so where this regulates on a 24-hour cycle, so with the sort of transcriptional translation feedback loop. And this is what gives us the sort of circadian oscillation over the day. So that's what the central clock, and there's a range of sort of other sort of fine-tuning mechanisms going on there. But in terms of what we actually know about sort of underlying polymorphisms in the general population, that until recently has been less well understood. So sort of back in the early 2000s, a few mutations in, say, the PER2 or PER3 genes were identified with sleep-wake disorders. But really, it's only been in the last 10 years or so with the rise of genome-wide association studies that we really identified genetic variants that underlie and can be kind of consistently associated with a range of sleep traits. So just sort of wanted to aggregate some of these studies, the genome-wide association studies that have been conducted in the last few years, to show just how many variants have been identified and the sorts of genes that are coming out. So as you see, we're really leveraging the studies that I've mentioned. So UK Biobank, 23andMe, the Million Veteran study I've not mentioned, but that is another one that has freely available data and some sleep measures as well. And the GWAS are being conducted now from sort of hundreds of thousands to millions of participants, and identifying some variants in genes that are sort of well known in the sort of circadian literature. So again, the sort of period and cry genes, and consistently identifying other loci. So PAX8 in relation to sleep duration and insomnia, MICE1. So a lot of these variants that are now kind of becoming more and more familiar and replicated across different studies. Also highlighting here the GWAS that have been conducted for accelerometer-based measures, so on a smaller number of participants, so largely leveraging the UK Biobank data. But again, identifying, very sort of biologically relevant variants, and as I said, there's some level of genetic correlation with the equivalent self-report measures as well. So just like I said, I wanted to go through a few examples of how we've been leveraging these genetic variants and using them to evaluate the role of sleep traits in relation to diseases, and I'll give a few examples of the diseases we've been looking at and the inferences we're making. So this isn't a study from our group, but it's a study from some collaborators in the US who were interested in looking at integrating both observational sort of prospective analysis of sleep duration in relation to myocardial infarction, and then also integrating the Mendelian randomization design. So observationally, there's a sort of well-established sort of U-shaped relationship where it seems that both short sleep and long sleep are increasing risk of myocardial infarction. And that's also what this study identified using data from UK Biobank. But in the Mendelian randomization design, although the sort of elevated risk of short sleep was sort of established and verified, this sort of U-shape wasn't identified in the Mendelian randomization. So actually, it looked as though with increasing sleep, the reduction of MI was reducing. So rather than a U-shape, sort of more of a linear relationship. And so the conclusion of this study was that short but not long sleep duration was a causal risk factor for MI. So the results are quite interesting and really speak to potential confounders or reverse causality, which might be explaining the observed link between longer sleep and cardiovascular disease. So we sort of followed up on this analysis and wanted to look at sort of replication in the Hunt study that I mentioned earlier, but also we were interested in investigating sort of pairs of sleep traits. So insomnia being sort of a common phenomenon, but with some people reporting insomnia having short sleep, other people with insomnia having long sleep. And we wanted to know whether there was any evidence of sort of synergistic relationship between sleep traits in relation to acute myocardial infarction. And we also wanted to look in relation to chronotype as well. So in the UK Biobank, we found some evidence to suggest that this is using the genetic risk scores for these traits, that in combination that they were increasing risk of AMI, but there wasn't a departure from an additive model, so suggesting that they're working additively to increase risk. In the Hunt study, however, we didn't find a huge amount of evidence for replication. Maybe we were slightly underpowered in Hunt. It's a smaller study. And so, so I think the results of this was a sort of hint of evidence that particularly insomnia and short sleep were in combination could be increasing risk, but this wasn't fully replicated, as I mentioned. So in relation to hyperglycemia, so this was a study conducted by a postdoc who was in Bristol, is now in Oxford, James Liu. And he wanted to do a very comprehensive assessment of using multivariable MR, one sample Mendelian randomization, so that's where we have genetic variant, exposure and outcome in the same sample, and two sample Mendelian randomization, which is sort of a more recent development of the Mendelian randomization design, which uses summary data, so GWAS of the exposure and a GWAS of the outcome in separate samples. And so James integrated the evidence from across these different designs, and also with a range of sensitivity analyses, which were essentially evaluating those underlying assumptions that I mentioned earlier, and found in particular quite consistent evidence for this increase in HbA1c levels in relation to insomnia symptoms. So finding consistent evidence that self-reported insomnia increased HbA1c. So I showed this plot earlier, or a similar plot. This was now with the HbA1c and glucose overlaid. And we were expecting, when we repeated this analysis using the accelerometer-based measures of sort of sleep fragmentation and sleep efficiency, that we might also find evidence that this increased HbA1c levels. But we didn't find a huge amount of evidence to support this. So so whereas self-reported insomnia was related to those glycemic traits, the accelerometer-derived measures did not seem to be. And so this was a surprising finding, and really sort of begged the question of what it is about self-reported insomnia that might be potentially driving this effect. So it's obviously something that isn't captured by those measures that we of efficiency of fragmentation. We think it could be potentially something related to sleep regularity that we're exploring further. And then the other thing I just wanted to show again was the relationship with sleep duration. So again, finding here a positive relationship between, a protective relationship between increased sleep duration and hyperglycemia. So again, similar story to the cardiovascular disease risk, we finding that increasing sleep duration is potentially protective. And again, we've sort of extended this in a sort of non-linear based fashion. So we see this U-shaped relationship observationally. We wanted to sort of repeat this in a Mendelian randomization design using both the self-reported and accelerometer-based measures. And again, we don't see the same extent of U-shaped relationship. So suggesting that sort of after the 7 hours of sleep, we're still seeing protective role of increasing sleep duration. Which is in contrast to the observational relationship. So I also wanted to mention, so a lot of the studies that we've used sort of previously to explore sleep have been quite primarily European studies. Increasingly, we have access to more diverse data sets, and I mentioned the use of the CKB, so China Kadoorie Biobank. We've just very recently run GWAS for some of their self-reported sleep traits, just shown a few Manhattan plots here, highlighting signals, some surpassing genome-wide significance and some replicating some of the signals we see in the European GWAS, so relating to sleep duration, sort of signals in PAX8 and other well-established genes. But quite interestingly for insomnia, so whereas in insomnia in European GWAS reveals a number of different hits that are all very, very interesting, in the CKB we didn't even find any genome-wide significant variants for insomnia here. Nonetheless, we've taken sort of hits that are sort of close to genome-wide significance thresholds to generate polygenic risk scores, and then performed Mendelian randomization using an East Asian outcome GWAS as well. So this is again looking at HbA1c, and find again some potential evidence for an adverse effect of short sleep on HbA1c, and also potentially snoring, which was another self-reported trait that we were including here. Okay, so moving on again. I wanted to sort of touch on a lot of the work I do is more on sort of physical health, so cardiovascular disease, cancer, but obviously, you know, increasingly aware that we can't really look at sleep without also considering sort of mental and cognitive health as well. This is some work that I've been doing in collaboration with Jessica Tyrrell and Renu Balu at the University of Exeter, who were very interested in sort of metabolic psychiatry and this link between diabetes and depression, which they've shown to be bidirectional. And as part of this study, we're really interested in understanding the extent to which sleep and potentially insomnia could explain some of that causal relationship between diabetes and depression. So what Renu did, shown on the right, is to look at doing some partial genetic correlation analysis. So looking sort of unadjusted at this strong genetic correlation between major depressive disorder and type 2 diabetes, and then including the sleep traits sort of sequentially in the model to see if that attenuated the genetic correlation. And quite interestingly, for insomnia, there's quite a large extent of attenuation of that correlation when insomnia was included. So it could suggest that insomnia is maybe confounding some of the effects or could be mediating some of the relationship. And so Renu has performed some causal mediation analysis, which has leveraged sort of Mendelian randomization and different instruments for diabetes, insomnia, and depression. And there's quite, I think, really interestingly found that about 23%, 24% of the effects of MDD on type 2 diabetes is mediated via insomnia. So suggesting that insomnia is a very important is playing a very important role in this relationship. And again, in the reverse direction, a much smaller effect, but still some evidence for mediation of type 2 diabetes on MDD via insomnia as well. And then the other sort of nod to sort of the more cognitive psychological traits is this work that we did a few years ago looking at sleep and Alzheimer's. So I think it's you know, quite commonly observed that people who have cognitive decline and maybe sort of early stages of Alzheimer's have the sort of classic sleep problems that are recognised. Again, cause and effect in this situation is something that is still sort of I guess under heated debate. We wanted to try and add to the evidence by using Mendelian randomization in this context, so using genetic variants related to a range of the different self-reported and accelerometer sleep measures. And I think quite interestingly, we found very little evidence to suggest that any of these sleep traits were having a causal relationship in relation to Alzheimer's disease risk. Maybe some sort of loose evidence for suggesting a protective role for daytime napping, but this wasn't really supported by our sensitivity analyses, so our sort of pleiotropy robust methods. So yeah, something I think that was quite surprising in the literature, given this, you know, as I say, very, very well-known phenomenon, and potentially providing more evidence for reverse course, so sort of early prodromal Alzheimer's being the factor driving poor sleep. Something to say, and I think is something that we need to explore a little bit further, is obviously these are quite blunt measures of assessing sleep, particularly in the sort of cognitive domain. And experts in this area would probably suggest, you know, it'd be better to look at sleep staging in relation to Alzheimer's disease risk. Obviously, it's quite difficult to do that using these sorts of measures that we have. You'd ideally want sort of polysomnography to be able to do that. But Aidan Doherty and other collaborators at the University of Oxford are trying to do this. So they're sort of training machine learning models of the polysomnography and wearable devices, and then sort of transporting those measures to the UK Biobank. And I think I'm finding quite interesting results regarding sleep stages, particularly sort of non-REM sleep in relation to cognitive decline. So another sort of sleep phenotype that I wanted to talk about was that of chronotype. So this is, as I mentioned, sort of the morning-evening preference, where there's some literature, particularly in relation to cancer, that this might be important. So I don't know if people are familiar with the sort of cancer literature. So circadian disruption is classed as a group 2A carcinogen, according to the International Agency for Research on Cancer. So that is probable evidence that it is a carcinogenic factor. And so a lot of this has come from sort of animal models, but also literature around shift work, so particularly shift work in the Nurses' Health Study, which was found to be linked with breast cancer. So as part of this study, we wanted to sort of explore whether chronotypes are not just in shift workers, but in the general population, whether if people had a morning or evening preference, whether that was related to cancer risk. And again, we sort of integrated the prospective analysis, 1 sample Mendelian randomization and 2 sample Mendelian randomization to find really consistent evidence that women who reported having a morning preference were 12 to 15% less likely to get breast cancer. This was quite surprising, but also in agreement, I think, with that sort of shift work hypothesis, the sort of light at night hypothesis, which could be driving breast cancer. In the same study, we also looked at some of the other sleep traits, and I think in contrast to the sort of cardiometabolic disease, here we're actually finding evidence potentially for a more detrimental effect of longer sleep duration. So some evidence that longer sleep duration might be increasing breast cancer risk. And then for insomnia, the evidence wasn't completely convincing, but if anything, it's in the direction of suggesting insomnia as a risk factor. So to sort of marry the two, sort of longer sleep duration, but as well as insomnia, that seemed a little bit conflicting, but may have been, or maybe potentially explained by sort of fragmented sleep. So when we incorporated the wearable data in this, we found some evidence to suggest that the number of nocturnal sleep episodes was positively related to breast cancer. So it might be that women were sort of reporting longer sleep duration, but that sleep was more fragmented. So we're now looking at this in more detail, wanting to look at replication in different studies. And I mentioned the All of Us US study, which we've just been starting to use. So this is sort of, I guess, comparable to the UK Biobank in terms of the scale of the genetic data. So both have got sort of genetic array data and whole genome sequencing data on around 500,000 participants. Although All of Us doesn't have sort of the same level of detailed questionnaire data, it does have the linkage to the electronic health records, and so we've been obtaining data from sleep diagnoses and information on sleep medication from participant EHRs. And there's also I think quite an exciting resource in the Fitbit devices. So around 60,000 participants from All of Us study have been wearing Fitbit devices, whereas in the UK Biobank people were only wearing the Act Watches for 7 days. I believe some participants in All of Us have been wearing Fitbit devices for sort of more than a year. So a huge amount of data that I think is quite exciting and ready to explore. And we've not yet looked at the Fitbit data ourselves, but have been looking at the electronic health record data. So I wanted to present just some observational analysis, so really leveraging the diversity of the cohort to look at associations between clinical insomnia and breast cancer across these ancestry groups. And the results so far are a little bit confusing. So when we use the sort of clinical insomnia measures, we find actually evidence for protective association, so inverse association between clinical insomnia and breast cancer. But when we incorporate medication use, so that's sort of insomnia medications into the definition, the effect estimate flips direction, so it looks to be positive there. So we're still quite preliminary results. We're not 100% sure what is going on, but Bryony Hayes, who's been doing this work, has also been incorporating the genetic data into this. So this is using the sort of short reads from the whole genome sequencing to run single variant tests, and has been running GWAS of those insomnia measures between the different ancestry groups here, using those two definitions that I mentioned. So this is just the sort of European subgroup. So sort of the two definitions, and then the hits, showing some sort of consistent hits between the two definitions. I think the most obvious signal is this really quite striking single variant WSB1, which we've identified, but then also some signals in other genes which have previously been associated with insomnia, but also have very interesting sort of biology in relation to other traits. As mentioned, like we've got a particular interest in breast cancer, so we've been sort of interrogating some of these signals and investigating enrichment in relation to cancer. So the WSB1 in particular has been linked to regulation of metastatic potential in HR-negative breast cancer, which is really interesting. As mentioned, some of these other signals have been sort of identified in relation to other sleep conditions, so MICE1 in relation to restless leg syndrome. That I think is shown in the next page is a signal that sort of consistently comes up in other GWAS as well. So this is the largest insomnia GWAS, which combines biobank and 23andMe. So we're showing some replication of other signals, but as mentioned, that WSB1 seems to be a novel signal. We're maybe a little bit wary. It looks a little bit too good to be true. It's such a strong sort of single signal. But when we look across the different ancestries, we're also showing consistent evidence as well. So this is in different subgroups that we're finding it in the African American and Hispanics, although it isn't coming up in the Asian group as well. It's not previously been related to insomnia, as far as we're aware, but does have some sort of interesting biology in terms of immune regulation, hypoxia, so something that we're sort of very interested in and following up. So just wanted to sort of complete the picture with the relationship with sleep and cancer. So this is some work that collaborator in Greece has been in the University of Ioannina, where he's looked at a range of those sleep traits in relation to a number of reproductive system cancers, and found actually, whereas we found quite strong evidence for the breast cancer link across the board, very little evidence for any sort of causal relationship between the other sleep traits and cancer risk. Perhaps with the exception of prostate cancer, where there was some potential evidence that, again, chronotype was potentially causally related to prostate cancer. And then in another piece of work in relation to colorectal cancer, which is the other cancer that's often implicated in relation to circadian disruption, some evidence that, again, so this is morning preference chronotype, was protective against colorectal cancer, but this seemed to be specific to males. So the conclusions of this study was, we weren't fully convinced that this was a very consistent finding, but again, maybe did support some of the previous literature. So I think another thing we're sort of increasingly interested in doing using the Mendelian randomization approach is to look into mechanisms. So if we've sort of established potential evidence for a causal relationship between sleep and outcome, we want to know what is the fundamental biology of the pathway. Not least because it might be quite difficult to specifically target sleep. Okay, we have insomnia medications, cognitive behavioral therapy, but things like chronotype, so a person's sort of intrinsic preference to morning or eveningness, is something that's quite difficult to try to target. Whereas if we can find, a pathway that's, or a mediator on the pathway that could explain a large proportion of that effect that might be more targetable, then that's quite an attractive potential therapeutic target. So we're sort of exploring a number of these mechanisms at the moment. I just wanted to show an example of looking at sort of hormone regulation, so in particular testosterone, which seems to be related to both chronotype as well as breast and prostate cancer. And we're finding evidence that this could be potentially explaining some of the relationship we see between chronotype and these reproductive cancers. So in particular here, what I'm showing is a multivariable Mendelian randomization, so where we've got genetic variants related to both the sleep trait, but then also the mediator of interest, so that's the testosterone measure. And where we see sort of attenuation of the univariable to the multivariable, that's indicative of potential mediation, which is what we show here. So as soon as we include the sort of bioavailable testosterone measure in the multivariable model, that we see some attenuation of that overall effect. So we've also looked at breast cancer survival as well. So we know it's a very common phenomenon that people diagnosed with breast cancer report insomnia, and this is something that is sort of potentially related to treatment, but is also, you know, well reported even many years after treatment as well. And if we can find evidence that sleep is potentially related to survival, then that's obviously something that's very important to highlight and potentially treat. There's various challenges of doing Mendelian randomization in this sort of progression, sort of case-only design. Without going into too much detail, and the issue is basically a sort of selection bias, so collider bias, where when we've conditioned on the disease of interest, so we're looking at sort of individuals who have only been diagnosed with breast cancer, we induce sort of a spurious association. So this could be like observationally between the sleep trait and the confounders, the things that we want to try and get rid of. But even in a Mendelian randomization context, it's still vulnerable to this collider bias. So even though in a sort of non-selected group, we might be comfortable that the genetic variants are not associated with the confounders, as soon as we sort of condition and we look at, say, in a case-only design, we can induce this spurious association, which then invalidates a lot of the Mendelian randomization assumptions. There are ways to get around that, so we can use these sort of index event bias correction methods, and that's what Bryony has done as part of this piece of work, and showed little evidence that any of the sleep traits was related to breast cancer mortality. Again, potentially with an exception of daytime sleepiness, where we were seeing that in the protective direction, but that didn't sort of surpass our multiple testing threshold. So again, we didn't really focus too heavily on that. We did, however, look in a different study looking at ovarian cancer, and again using these same correction methods, where we did find potential evidence that insomnia was increasing mortality risk in ovarian cancer. So it was quite an interesting finding. So I know we're a little bit short on time, but I also just wanted to give some examples of how we've used this Mendelian randomization approach to appraise risk factors in relation to sleep as the outcome. So I'll just quickly give a few examples of how we've done this in relation to looking at nicotine in relation to sleep, vasomotor symptoms, those are the sort of hot flushes and night sweats experienced by women going through the menopausal transition, as well as some work that we've done looking at spousal sleep as well. So in relation to nicotine metabolism, we've again leveraged this multivariable Mendelian randomization design as a way to establish for a smoker who has sort of variable levels of nicotine metabolism, to investigate how this is related to sleep. And what we found within this model is, for a given level of smoke exposure, individuals who are metabolizing nicotine faster are potentially more likely to have a morning preference. They find it easier to get up in the morning and also have a greater ability to nap. So we think this is quite interesting in suggesting that sleep could be impacted in individuals who are undertaking nicotine replacement therapy. We've also done a similar study, I'm not showing it here, but looking at caffeine metabolism as well, and finding some evidence that genetic variants that influence caffeine metabolism are also relevant in relation to sleep behaviour. So quickly, the vasomotor symptom study is something that we're currently very excited and interested in. So we often assume with Mendelian randomization that we're looking at sort of lifelong effects, because we say genetic variants are inherited at birth. But actually what we can show is that that the genetic signals might differ, so there might be some sort of timing specific effects going on. And this is just one instance of where this seems to be the case. So a genetic variant in the TACR3 gene has been really strongly related to vasomotor symptom risk in previous GWAS. And we were interested in investigating whether this was also the case in relation to menopausal insomnia, particularly because there's a new drug that's come to market called fezolinetant, which directly targets the protein encoded by the TACR3 genes. This is this neurokinin 3 receptor agonist. And we're interested in investigating whether this drug could be potentially repurposed, as insomnia is a sort of a second most prevalent condition reported by women going through menopause after vasomotor symptoms. So what we found for this TACR3 variant is a signal of association with insomnia, which was particularly strong in relation to women, so actually didn't exist in relation to men, and also was sort of reaching genome-wide significance only when we looked at women around menopause age, and so again wasn't there in premenopausal women. And we also found evidence that this signal was there in women who did and didn't take HRT, which we're using to indicate that this might be a signal that's sort of independent of vasomotor symptoms. And we also showed strong evidence for genetic co-localization of this signal between vasomotor symptoms and insomnia as well. So as I said, it's quite exciting work and something that we're following up within this kind of drug target and de-anonymization framework. Potentially to look at sort of novel therapies for treating insomnia within particularly at-risk subgroups of the population. So I think finally is the example I wanted to talk about was looking at sleep between spouses and leveraging de-anonymization to be able to do this. So being able to estimate so within a couple, whether there's any evidence that one spouse is impacting the sleep of another spouse. And we did this using data from UK Biobank as well as 23andMe. And we found quite interesting evidence that in relation to chronotype, the diurnal preference of chronotype was inversely related between spouses. So if one person reported being a morning person, the other person was more likely to be an evening person. But when we looked at diurnal activity, so that's the sort of timing behaviour that people are actually doing, not their preference, we found that these were positively related. So potentially within a couple, their behaviour is going opposite to what their intrinsic preference is. But for sleep duration, we found evidence that of a positive relationship. So increased sleep duration in one spouse, increased the sleep duration in the other. So this was all used to sort of show evidence for these partner interaction effects, and we were trying to dissect that from sort of assortative mating, which could be possible on sleep traits, presumably, and then also social homogeny or sort of more general confounding. So just I wanted to show this as sort of novel use of de-anonymization, particularly to unpick causality within sort of family units as well, which I think for sleep is increasingly important and of interest. I'm just sort of conscious of time, but I think what I've talked about more is sleep rather than sort of circadian disruption. And I think it is circadian disruption that is the thing that we would like to be able to identify and potentially assess causality of using de-anonymization, but there are various challenges in being able to do this. So yeah, we can look at sort of various measures of circadian disruption. So I've talked about shift work as a potential proxy, things like sleep inertia, so that's sort of difficulty getting up in the morning, and social jet lag. There's various accelerometer-derived measures that we can use to proxy for this. But increasingly, we're looking at potential molecular measures which might serve to underlie sort of circadian disruption. Why this is sort of challenging from a de-anonymization context is just in terms of the instruments we can use. I think circadian disruption is maybe quite sort of conceptually you can see there's a sort of gene environment interaction, and it's sort of we're acting against what our intrinsic rhythm is telling us to do. And you can't just, for example, use genetic instruments from, say, a GWAS of shift work. If we were to do that, well, we have done that. We've done a GWAS of shift work, and the top signals we get are educational attainment and things like body fat percentage, which obviously aren't specific genetic variants for this type of behaviour, and that would sort of reintroduce confounding into the de-anonymization design. So what we can do is we can look at instruments in things like sleep regularity, so how consistent people's sleep patterns are, and potentially looking at the sort of interaction between self-reported sleep preference and then also actigraphy-derived sleep as an actual pattern of behaviour as well. I'm very conscious of time. But just wanted to highlight if we were looking at shift work, something that we've done is investigated using Mendelian randomization if there are any factors that influence people's engagement or participation in shift work. And we found, again, that education is something that really drives whether somebody becomes a shift worker, as well as body mass index, which is quite interesting. And there are some sleep traits as well. So a person's ability to nap during the day, and also the sort of sleep duration that they need, are things that might indicate shift work tolerance, so the ability to undertake shift work. I'm going to skip over this, but this is just to say that, as I mentioned, sort of we're interested in sort of internal biomarkers of circadian disruption, and we're looking increasingly at the sort of proteomics data. And this is using the UK Biobank Olink data. I've found really interesting evidence of circadian patterns within the proteomics. So there's varying levels of protein abundance across the day, which for some of these proteins just follow a circadian pattern. And this is something we're very interested in following up. So in conclusion, so poor sleep and circadian disruption have been associated with a range of diseases. Whether these links reflective of causality is something that's particularly of interest to us. And so we've leveraged biobank level data from self-report, accelerometer measures, electronic health records, as well as genetic data, as a way to sort of appraise the role of sleep and circadian rhythms in relation to physical and psychological health. And I've given a few examples of the types of study designs that we can use to do this, and some of the sort of early findings we have. In particular, highlighting, for example, the potential role of insomnia in relation to CVD and type 2 diabetes, as well as potentially in relation to ovarian cancer survival, the detrimental role of short sleep duration, potentially not short sleep, long sleep duration in relation to CVD and type 2 diabetes, and then also the role of chronotype in relation particularly to breast and prostate cancer. I've also introduced how you can use Mendelian randomization to look at mechanisms. So for example, highlighting insomnia as an important mediator between depression and diabetes, and testosterone as a potential mediator that chronotype on breast and prostate cancer. But we can also use MR in other ways. So, for example, to look at other circadian traits and sleep behaviours, such as those of shift workers and those between spouses. And we can sort of repurpose the Mendelian randomization design as a way to look at potential therapeutic targets. So very briefly talked about nicotine metabolism and vasomotor symptoms as examples. So next steps, so I've mentioned how we've started to use some of these more diverse data sets to look at the sort of genetics of sleep traits, but also to look at potential heterogeneity between different ethnic groups. Also to sort of refine our assessment of circadian measures using accelerometer data, but also potentially incorporating more omics data to investigate those molecular pathways which underlie circadian disruption. And yeah, just to finally highlight this sort of new data source that we're very interested in, that people are probably familiar with, and this new data that's just been released from the UK Biobank. So a very detailed sleep questionnaire with measures on sort of sleep behaviour, work and sleep, a range of insomnia measures, as well as family history. So that's something, again, very interested in investigating in more detail. And there was a webinar held just last week from Martin Rutter and collaborators Simon Kyle and Han Grian at Oxford to talk about the release of this data, which is saying we're very excited to start using. Great, and a range of acknowledgements from all of my collaborators, particularly the team at Bristol and Oxford, but others as well who I've worked with over a number of years. I want to just say thank you very much for listening.
For the course. That's fantastic. Thank you. Do you have any questions for Rebecca? There's a couple in person, a couple online. Hi, Helen. How you doing?
Thank you. That's really fascinating. Have you looked at ADHD at all as a mediator or a confounder?
No, to be honest, perfectly honest, we haven't. No. Yeah. I think it'd be really interesting. So this is me not coming from sort of not coming from a psychological mental health space, that I think it's obviously increasingly important to look at sort of particularly the genetic overlap and also the timing specific effects. So looking at sort of earlier life sleep. Yeah, not something we've specifically looked at before, but it's very interesting to look at.
Check for a couple online. Excuse me. I have a couple of burning questions. Right, Angelina?
Yes, thanks for a brilliant talk. You covered so much research. That was incredible. Many questions I would ask, but let's start with just one for now. When you look at the discrepancy between some of the self-reported data and the experimental derived data, do you think that's due to data ignorance on the part of participants who don't really know how to fill out these questionnaires, or do you think that's to do with the devices?
Yeah, it's a really good question, and I think there probably is some sort of systematic error in terms of the discrepancy of the reporting. So I think, yeah, like, so for example, I don't know, there's like this sort of phenomenon of paradoxical insomnia that a lot of people diagnosed with insomnia, it wouldn't necessarily show up on an actigraphy trace, that they don't have those characteristic fragmented sleep or low sleep efficiency, but nonetheless would still be clinically defined as an insomnia case. And then on the flip side, so yeah, interesting. So it's again not really my field, but with the Alzheimer's disease example, I think that there's evidence that people with dementia, early dementia, actually would report having a good night's sleep, even if objectively they aren't having a good night's sleep. But whether that is, them forgetting that they have woken up in the night, or they just sort of, that relative to what they're used to, they say, oh yeah, I've had a good night's sleep. So I think, like I said, there is some sort of potential systematic bias. In terms of what the devices themselves are detecting, so yeah, as mentioned, I suppose that there's always some level of error, and in terms of the crudeness of the device, that's something that, yeah, I think working with, I know obviously like Laura and other people here have done a lot of the working with the wearable devices, and others at University of Oxford, so talks about Aidan Doherty, and particularly sort of training those measures on the sort of gold standard polysomnography to get more refined sleep phenotypes. I think is something that, yeah, should definitely be done.
Mind me asking the second one?
Yeah, that's fine.
Just when it comes to the spring clock change, I wonder if there were any benefits of that at all. It seems like there's lots of bars types. What about something?
Yeah, so I say we did find the beneficial effects with the autumn clock change. So that's the gaining an hour. It looked as though that seemed to be protective, but I don't think you would say advocate a clock change just to see a protective effect on, when switching the clocks back. So yeah, I think Mel's sort of grappling with the interpretation of those results at the moment, because I think that's the sort of protective effect on the shift back is something that hasn't really been reported in the literature. And yeah, I think the consensus would still be generally just keeping a consistent time and not doing the clock changes.
So we'll do, I think, Claire, did you?
I do have a question, but I can wait if you want to do something else's.
We'll do Ben, then Claire, then Ahmed, and maybe time for one more. So Ben online has asked, I'm still not convinced how MR can avoid reverse causation, e.g. between HbA1c and self-reported insomnia. How do you know the genetic link is not with one rather than the other?
Yeah, no, it's a really good question. And I think we can try and tackle it in two different ways. So obviously one is, well, maybe in three different ways. So one would be sort of the knowledge of the genetic variants that we're using as the instrument. So if we're sort of more convinced that they are sort of circadian variants, for example, we could sort of target them and do anonymization to using those variants that we know are sleep variants as opposed to HbA1c variants. We can do obviously like a range of sort of pleiotropy assessment measures. So if we found, for example, of a range of genetic variants, like a particularly strong outlier of one variant having a larger effect on HbA1c than the sort of average of the other variants, then we might indicate that outlier is because it's having an effect on the outcome that isn't necessarily via insomnia, and we can correct for that. And then there's sort of more sophisticated measures, so where there is evidence potentially of bidirectionality between exposure and outcome, is to do a sensitivity test called Steiger filtering, where you essentially look at the proportion of the exposure and the outcome explained by the genetic variant. And if more of the outcome is explained by the variant than the exposure, then we could exclude that variant again from the model to be able to sort of harness the correct direction, so orientate the correct directionality there. Yeah, so there's a few strategies that we can use for that.
Claire?
I was wondering if you know anything about like people's perceptions of insomnia. So my brother's had insomnia since his early 20s, and he would hate this talk because he hates hearing about all the other potential negative effects of insomnia, which he's tried everything and it's very difficult to tackle. Whereas I have a friend who has insomnia and it doesn't seem to bother her that much. She just sleeps less than other people. And so that it definitely affects them differently psychologically. But I was wondering if perception, if there's any evidence that that's associated differently with physical outcomes, or if there's not the data to look at that.
Yeah, so I think that's a really important point. And I think previously using the data sets we've not really been able to disentangle that. Obviously, the sort of clinical measure of insomnia would be that sort of daytime dysfunction, as that people aren't functioning well in the daytime, directly attributed to the sleep. Whereas, maybe your friend can still function even though, like, she would say, I don't have particularly good sleep. That's something that we can do through sort of the record linkage to an extent. But I think with the comprehensive sleep questionnaire and biobank that's now gone out, where there is a lot more about the sort of subtypes of insomnia, the sort of case definition of insomnia, that's something we could look at and see if we can pick out sort of differential effects.
I should say I loved your talk. That sounded a bit negative there. I hate reading about this kind of thing, but it's very interesting.
Also, that's it, when it's something that people have I think, just put up with and maybe adapted to across their life, to hear that, that could be potentially having detrimental effects.
He's always like, brilliant, tell me another thing that's bad about it. Thank you.
Ahmed, leave it at the back.
I think as particularly and so
Yeah, so the question was, have you looked at medications much in terms of side effects?
Yeah, so we have often, when we actually do the GWAS analysis, we will exclude people on medication use. So we often do a sensitivity of trying to do that. As mentioned, when we were using it, all of us, we tried different definitions, and actually we're quite interested in people that were using sort of hypnotics to see if it revealed anything different. A problem with doing sort of de-anonymization of insomnia medication is sort of confounded by indication, obviously. But it's something that we are sort of increasingly interested in. So I mentioned that particular example with the vasomotor symptoms and insomnia and a new drug there, but also whether you could potentially use a sort of drug target de-anonymization to evaluate potential long-term side effects of other medications as well, insomnia medications, and that's something that we're interested in doing.
Well, thank you so much. That was an absolutely tremendous talk, an absolute tour de force. So if you could give Rebecca a big round of applause. Have a good afternoon, and thank you for coming, everybody. Thank you, everyone. Great. Well, that's fantastic.
Thank you.
That was amazing.
Running over.
No. I'll send the chat here and red lunch. Thank everybody online too.